Good afternoon. Hello. My name is José Moreno. I am Chief of the Pediatric Department in Clínica Universidad de Navarra in Madrid, Spain. And it is my pleasure to share this DSM symposium titled Building a Foundation for Infants' Health, especially devoted to the role of LCPUFAs and the HMOs. We are very glad to have with us as main speakers two great professionals and experts in the field, that are Professor Bertolt Koletzko from Munich, Germany, and to Professor Sharon Donovan from University of Urbana, Illinois, United States. Thank you to all of you for attending this symposium, as well as those online, and we wish it will cover your expectation. The timeline of the session will be a short introduction on early life nutrition, lifelong, followed by the two lectures from both speakers, and at the end we will have around 10 minutes for questions or comments. Non-communicable diseases are the results of a combination of genetic, physiological, environmental, and behavioral factors. The main ACDs are cardiovascular diseases, cancer, chronic respiratory diseases, and diabetes. All of them kill 41 million people yearly worldwide. Each year, more than 50 million people between the ages of 30 to 69 died from a non-communicable disease. And 85% of these premature deaths occur in the low and middle income countries. This is also accompanied by a high economic cost and is projected to show steeper increases in the future, especially in the less developed economies and also among the poor in the middle and high income countries. We know that there are some modifiable risk factors associated to these chronic diseases, that are tobacco use, physical inactivity, unhealthy diet, of the harmful use of alcohol. But besides this, we have some metabolic factors that could be modified, that are mainly high blood pressure, hyperglycemia, overweight, obesity, or diabetes. Traditionally, of these metabolic risk factors has been addressed in the adult life, and some of them when one or more of them risk factors are already present. Fortunately, during the last 30 years, it has been developed the concept of early life nutrition. That means the importance of nutrition in this critical period that goes from the conception to the end of the second year. Is called the 1,000 days. During these days, this critical period of window of opportunity, all the nutritional factors could help to modify these metabolic risk factors for these chronic diseases. We know that this influence of environment during the fetal life and the infancy, mainly I have said before, the 2 first years, are trying to give a trend to these phenotypic effects in later life. So all the things we could do in this time could help to decrease the risk of becoming obese, having high blood pressure, developing diabetes, or hyperlipidemia. Even more, we know that some of these conditions may transfer from one generation to the other generation. So there is a growing evidence that the effects of developing programming may also manifest in further generation without further suboptimal exposure. And this makes us a challenge not only for our young people, but further generations on. All of you are aware that behind this metabolic programming, there are a lot of physiological explanation, and that metabolic epigenetic changes, that means the changes that affect the expression of the gene, but not really the DNA, are on the bottom of these changes. These, besides the change in the microbiome, are probably one of the two explanations, of physiological explanation, and why in this critical period of life, these influences have an important role. In the last few years also, this metabolic risk not only affects to the metabolic diseases, as I have said before, that also may influence the neurodevelopmental programmation. And some of these risks can have also developed the risk for neuronal disease, mainly mood disorders as anxiety, depression, autism, and others. If you take a look at the program in the ESPGHAN meeting for these years and the last couple of years, part of the program is devoted to the microbiome. And why is this? Because microbiota represents one of the most significant features contributing to physiological interindividual variability. And we know that gut microbiome goes closely to immune maturation and metabolic maturation. One of the ways we could modify the risk of having an NCD is trying to get the ideal gut microbiome. And my last slide from this presentation is what can we do try to correct this tendency or this trend? We have part of the solution. We know that human breast milk is the reference for early life nutrition. It not only provides water, proteins, and lipids, and lactose, it's a blend of bioactive factors that may have an influence in improving or in programming this metabolic trend. In this session, we will talk only about two of these components of human milk that are arachidonic and DHA, as well as HMOs, in order to see how the knowledge we get from the advantages in the knowledge of human milk can be implemented in infant feeding. This is also the opportunity for the food infant industry, to provide the better nutrition to get our kids not only safe for today, but for all the lifelong. And with no more time to give time for my colleagues, please, Professor Koleko, would you mind to come to the stage?
The topic I was given today is, should infants be supplied with both omega-3 docosahexaenoic acid and omega-6 arachidonic acid? I am very grateful for the support of DSM Nutritionals for this session, but I don't report a conflict of interest with respect to the work I'm presenting, which was funded by the European and German public funding agencies. So you all know that polyunsaturated fatty acids are essential. We need to get them on a daily basis to maintain our health. We get with our diet both the precursor polyunsaturated fatty acids that we find in vegetable oils, linoleic and alpha-linolenic acid, omega-6 and omega-3, as well as from animal foods, the long-chain PUFA, ARA, and DHA and others. And also in our metabolism, we can convert the vegetable oil fatty acids to these long-chain PUFA. But this metabolism is slow in humans, and it's also very much genotype dependent, which I will show you in a moment. And then, of course, our status depends on how much is disappearing from our circulation. And of course, in periods of rapid growth, in infancy, for example, there's a lot of these PUFAs incorporated in tissues, and therefore the turnover is higher, the requirement is higher. We have a lot of indications that the status of PUFA and LCPUFA modulates health, membrane and tissue functions, cardiovascular and immune health, neurocognitive and visual functions, and other endpoints. So the two key components that we deal with are arachidonic acid, or ARA, and omega-3 DHA, or docosahexaenoic acid. Both are not found in vegetable oils, they're only in animal lipids, DHA mostly in oily fish. ARA contributes about half of the omega-6 fatty acids in brain and is high in all tissues, particularly membrane-rich tissues. DHA contributes almost all of the omega-3 fatty acids in brain and in the retina of the eye. Both are actively transported from the mother to the baby across the placenta and are provided with human milk. Arachidonic acid has been shown to be important for cell growth and mediates immune function and cellular regulation. Omega-3 DHA was shown convincingly to reduce preterm birth if provided in pregnancy. It's associated with less postpartum depression and with child visual and cognitive development, as well as less allergy and infection risk in some studies. So as I told you, the Vegetable oil fatty acids here at the top, omega-6, omega-3, can be converted to these long-chain PUFA, but the conversion that occurs with consecutive desaturation and chain elongation is pretty slow, particularly for DHA, which has a much longer and more indirect pathway of synthesis. And you can see these fatty acids, the long-chain PUFA, are not only important as structural components for cell membranes, but they're also precursors for eicosanoids and resolvents that mediate many functions like inflammation and immunity, very powerful at low concentrations. Now, as I said before, the conversion activity is very much genotype dependent. We have on our chromosome 11 a cluster of 3 FATS genes, fatty acid desaturation genes, and more than 500 single nucleotide polymorphisms are known today that mediate the activity of the conversion, the ability to form the long-chain PUFA from the vegetable oil precursors. Now, why are we so interested in these fatty acids in early life? Not only because of their impact on immune development, but also because they are deposited in relatively large amounts in the growing human brain, both during the last part of pregnancy and in the preterm ex utero, and continuing during the period of rapid brain growth for about the first 2 years of life. And while a lot of attention has been put to omega-3 DHA, as you see here, there's actually more omega-6 arachidonic acid deposited in the brain than omega-3 DHA. I said to you before, the fetus doesn't need to synthesize them really, because there is a very active preferential placental transfer of ARA and DHA from the maternal to the fetal organism. We have actually published some data, particularly with a group of Elvira Lake, to describe the fatty acid binding proteins and transporters that facilitate this active transport. And whenever you have an active transport mechanism in biology that works against the concentration gradient, you tend to think there must be a biological reason. Why does human nature invest the energy to transfer these fatty acids actively to the fetal organism? We would assume that they are beneficial to be provided in early development. After birth, also the breastfed baby doesn't need to form these fatty acids from precursors, because human milk provides both arachidonic acid and DHA in amounts that are believed to cover the needs for tissue accretion. And if you look here at this study with 2,500 women from around the world, you see the mean arachidonic acid in human milk is 0.5%, more than the content of DHA, which is 0.3%. The variation of arachidonic acid is pretty limited. Arachidonic acid is very stable in human milk wherever you go. DHA is a bit more variable, and it is particularly responsive to marine food intake, so coastal populations that eat a lot of fish and marine foods, tend to have higher DHA in the milk. What's interesting is that several studies have reported that arachidonic acid and DHA in human milk are correlated. You see here on the left a study that we published already 30 years ago in German women, where we see this correlation in milk for term infants with a mean ratio of 1.8 between ARA and DHA. And a recent study in Canada with milk for preterm infants, mothers of preterm babies, find the same, with very much the same ratio as well. So overall, arachidonic acid tends to be provided in large amounts, almost twice as much in human milk than DHA. Does it matter? The European Food Safety Authority has evaluated data on visual development more than 10 years ago and concluded that a cause and effect relationship has been established between the supply of DHA at a minimum amount of 0.3% of the fatty acids, so similar to the mean value in human milk, and visual function that is achieved at 1 year. And you see here there is a dose-response relationship. What EFSA has not emphasized actually at that time was that all these studies were actually performed with formula that provided both DHA and arachidonic acid. We know that breastfeeding is associated with a long-term benefit in cognitive development. This meta-analysis performed on behalf of the WHO concluded that overall breastfeeding provides a benefit of 2.5 IQ points if you adjust for stimulation, interaction with the child, and maternal IQ. Of course, we're not sure how much of that is really due to the biochemical effects of human milk or to other factors, residual socioeconomic confounding, or more interaction between mothers and infants when breastfeeding. But the hypothesis is of course there that the lipid components in breast milk could contribute to this effect. However, if we look at the randomized controlled trials that have looked at the developmental outcomes of infants randomized to formula with and without LCPUFA, the results are heterogeneous. In this meta-analysis, for example, IQ at 4 to 6 years had no overall benefit. But you also note that the I-square is 72%. And you know with an I-square of 72%, the recommendation is actually not to do a meta-analysis because it's too much heterogeneity. And you see that here visually, the 4 studies are completely different in their results. So it's not a situation where we have a clear conclusion. And if you look at the details, we know there is a lot of heterogeneity in the studies, in the interventions, in the assessment of outcomes. So it's a complicated situation where we are not sure what exactly the situation is. In preterm infants, it's more straightforward. In preterm infants, there is a consistent data showing benefits of LCPUFA supplementation of preterm formula for mental development, and a trend also for benefits for psychomotor development. There's another recent study here from Scandinavia, from Norway, that I find very impressive, again in preterm infants, where preterm infants were supplemented with enteral arachidonic acid and DHA in the same ratio that we find in human milk, 2-to-1 ratio. And in fact, this supplementation reduced the risk for severe retinopathy of the premature by 1/2 if adjusted for other factors. And you can see that the risk reduction is associated both with the arachidonic acid and DHA levels in the blood. So both arachidonic acid and DHA were predictive for this risk reduction. Now, I told you before, we have this interaction of diet and genotype in determining the metabolism and in fact also the outcome. In Europe, 3/4 of the population have a haplotype that promotes an active desaturation activity, and therefore if you look in the blood of these people, they have more arachidonic acid and less linoleic acid. And 25% of the European population have an inactive genotype. In other words, they have more substrate, less arachidonic acid, they have a very low conversion activity. Now that's different in other parts of the world. In Latin America and in Asia, most of the population have an inactive conversion, and a minority only has an active conversion. Interestingly enough, when we look at the effect of this genotype variation, it has marked effects on omega-6 fatty acids. So you see here DGLA arachidonic acid variation is markedly affected by the genotype variation, whereas it has a very modest effect only on the omega-3 fatty acids. Now, why is this important? Because it tells us a little bit about the potential importance of the omega-6 fatty acids. For example, in this study, the ALSPAC study, where some 6,000 children were tested for IQ, for intelligence, at school age, at the age of about 8 years. And you see here the IQ result, and you see that, interestingly enough, there's a genotype effect. Children with the GG genotype for the FATS gene that do not synthesize arachidonic acid have at school age a lower IQ if they were formula fed in the beginning of the 90s when the study was started, formula without added arachidonic acid and DHA. They have the lowest IQ, a marked difference. We consider this Mendelian randomization, the power of a randomized trial, because we believe the genotype is not associated with any other lifestyle choices or socioeconomic factors that would predict IQ development. Now, if we compare this with the IQ result of the breastfed children, you see that overall the breastfed children have a much higher IQ, and partly this is probably due to the different socioeconomic background of the families who choose to breastfeed. But you also see that here there is no genotype effect at all. In other words, if children get preformed DHA and arachidonic acid, it doesn't matter whether they can synthesize it themselves or not. The preformed provision with human milk suffices, apparently, to provide the needs for brain development. I think this is a very strong study showing us that early LCPUFA supply matters for cognitive development long term. And again, because this genotype variation affects particularly arachidonic acid level, it's tempting to speculate that it is arachidonic acid that is really important here. There's also another observation that we found in our group in Munich, again for interaction of breastfeeding and genotype with the occurrence of doctors diagnosed asthma. We looked at 2,245 children from German birth cohort studies where the children were followed from birth to now adulthood actually. We determined the genotype variation for the FATS genotype, looked at information of infant feeding, and doctors diagnosed asthma all the way from 6 months to 10 years. What did we find? Well, in the children that had the more common genotype that can synthesize arachidonic acid and DHA, there was really no effect of breastfeeding on asthma prevalence up to 10 years. But if you look at the subgroup of children that cannot synthesize the LCPUFA, then you suddenly have a strong effect. If children were breastfed for at least 3 months or longer, then the risk of asthma was basically reduced by 1/2. So how can this be explained? Well, as I told you before, in utero, there's a lot of LCPUFA deposited in the baby's body. After birth, these body reserves suffice to cover the needs for the first weeks of life. But then if you have no breastfeeding and were fed a formula without DHA and arachidonic acid, you are depleted. If you can synthesize yourself the LCPUFA, it's fine for asthma, but if you cannot, then the breastfeeding really matters. So you could consider that in the future, women, for example, doctors that are thinking about the question, do I need to go back to work or do I continue breastfeeding after 3 months or 4 months or 5 months, would want to choose genotyping their baby and then to decide on their feeding choices to make sure there's an optimal outcome. Now, many expert committees have looked at the question, what should be the best supply of LCPUFA for babies? And you see here there is consistent conclusions that babies should get, particularly in the first half year of life, arachidonic acid and DHA together. And all the recommendations recommend more arachidonic acid than DHA, 1.5 to 2 times as much arachidonic acid as DHA, following the model of human milk. Interestingly enough, although the European Food Safety Organization Authority had also recommended this, the European legislation that was put in place since February last year, 2 years ago, February 2020, came to a different conclusion. It said, based on the evidence that LCPUFA is important, that all infant and follow-on formula in Europe must contain DHA at relatively high level, more than we used to have before, 20 to 50 milligrams per 100 kilocalories, which is a typical fat content is 0.4 to 1% of DHA. But the addition of arachidonic acid is thought to be optional. It's not a requirement to add arachidonic acid. And first products then have appeared with this relatively high level of DHA, but without arachidonic acid. So this has raised a lot of controversy and concern, because infant formula with about 0.3% DHA and an arachidonic acid to DHA ratio between 1 and 2 have been studied in numerous trials and have been used around the world for many years, whereas the concept in the new European legislation is completely novel, and there's not a single published trial that has evaluated this. So the question was raised, is this a prudent or safe concept? Well, there is indications that this may not be a good idea. For example, from this trial by John Colombo and co-workers who randomized term infants to 4 different formulas, 1 formula without DHA and arachidonic acid, and 3 formulas with the same amount of arachidonic acid, but different levels of DHA, 0.3, 0.6, and 1%. And looking at this, you might expect the more the better. The more DHA you give, the better will be the outcome. That might have been the hypothesis of the investigators as well. However, if you do this, you also change the ratio of arachidonic acid to DHA from 2 to 1 to less than 1. Now, what was the outcome? I just show you 2 test results. At 4 years, there was this test of executive function, a very well established test that also NIH uses in their toolbox. And you see if you add DHA, then compared to no DHA and no AHA, actually the executive function at 4 years improves. Again, after infant feeding, not feeding at 4 years. At 0.6%, it becomes better. But at a higher DHA intake, the result becomes attenuated again. So with a lower arachidonic acid to DHA ratio, the outcome is worse. And the same is true for verbal development, language development at 5 years, at a level of DHA and arachidonic acid that is similar to typical human milk values. There is a markedly improved language development at 5 years. But at higher DHA and lower arachidonic acid to DHA ratios, again, the result becomes worse again. So bigger is not better in this case. Why is that? Well, a study in infant baboons, in non-human primates, has shown if you give these formulas, high DHA and low arachidonic acid to DHA ratio, you actually change the brain composition, reduce the arachidonic acid content in the brain in some regions in these infant baboons. So based on these and other considerations, a global group of experts that was pulled together by the European Academy of Pediatrics together with the Child Health Foundation recommended strongly that until we have better evidence, infant and follow-on formula should provide both DHA and arachidonic acid together with DHA levels of at least 0.3%, preferably near 0.5%, to also cover higher needs of subgroups, and at reasonable DHA levels up to 0.6%, which have been tested, arachidonic acid levels should be at least as high as DHA.
Well, thank you, and thank you for inviting me to speak today. And these are my disclosures, none of them affecting my presentation today. So we'll briefly review the structure and HMO levels and variation. I think this is not a new topic for most of you. And then again, I will summarize where we are in terms of findings from randomized placebo-controlled clinical interventions. And I would, though, refer you to this wonderful booklet that's been pulled together that's outside, because there are some studies that I'm not going to be presenting that are in that, as well as just a really nice review of the functions. And then I want to compare with some of the observational evidence, because we have kind of 2 bodies of evidence. We have the very well-controlled, randomized controlled trials of supplementation infant formula, but then we have observational data where the normal variation in human milk allows for looking at associations with outcomes. And then finish kind of briefly with some proposed mechanisms and a study where I think that we can actually revisit existing data and apply techniques like machine learning to understand mechanistic work in human studies. So I want to take a step back, because today we're really focusing on HMOs and LCPUFAs, but I think as Juan mentioned, you know, the evolving concept is really that human milk is a biological system, and that this is a nice figure, but I have to tell you, HMOs is not on here, so that's a little bit of an issue. But this concept that we can't just look at one of these, and it really works together in a complex matrix. And that also that human milk is a system within a system, so we have a very complex interactions. You've heard about milk fat globule membranes and lactoferrin and osteopontin and all of these individual components, but they're all working together. And that because of the uniqueness of the mom's ability to react to the environment, as well as the genetics that Bert just mentioned, which I will talk about genetics with HMOs as well. But we have that there's what we now call the triad, which is basically the lactating parent, human milk, infant triad, so that milk can adapt. So for example, with COVID, the production of COVID antibodies. But we do know from both direct clinical trials and epidemiological data that human milk does enhance child systems development and health. And I think that was what Jose was also referring to in his introduction. So focusing on HMOs, and this is probably a common graph that you've seen, the unique aspect here is that human milk contains a large quantity. It's the third most predominant solid component, but it's much lower in bovine milk. So traditionally, cow milk-based infant formulas have been pretty much devoid of HMOs, and part of, to fill that gap, we were using different prebiotics. And now there's more of a push as HMOs become available in sufficient supplies that we can begin to supplement them. So you can see the differences of a range of 3 to 16 grams per liter in human milk versus about 0.05. But the structures are similar. We see different, also human milk is unique in the numbers of structures that are there, and particularly the degree of fucosylation, which is different than any other species, including great apes, that we would think would be most closely related to. But if you have 6SL in bovine milk, it's structurally identical to the 6SL in human milk. So even though we call them human milk oligosaccharides or bovine milk oligosaccharides, they're structurally the same. So again, you may have seen this, but basically we start with 5 core monosaccharides shown here, and we also start with a core structure of lactose. And basically these can be elongated, fucosylated, and silylated, and this is where we get up to the 200 different structures. And so we oftentimes categorize them as neutral fucosylated, neutral core, these are sometimes now referred to as acetylated, and the acidic silylated. And this is a recent review which basically shows human milk mean from 14 to 90 days of lactation. And so you can see that in what we'll refer to as secretor mothers, the 2FL or 2-fucosyl lactose is the predominant HMO, and then also some of the elongation products of 2-fucosyl lactose. And this just to show you, this is data from the child cohort in Canada. So these would be the milk of non-secretors, and typically, so this is about a third of the mothers in the cohort, and this is 2FL. So what we typically see, the absence of 2FL, is that the milk of non-secretors has quantitatively less HMO available, and this is just as a percent of total. This is another nice figure that, as we see in the non-secretor mothers, there's other HMOs that are in some ways almost compensating for that. We see more LNT, more 3FL, and others. So, while we talk about human milk oligosaccharides, I'll mention that we do need to think, just like Bert was talking about genetics, that there are genetic differences, and so infants are not receiving all the same human milk. And so this is, again, a recent review that I will refer you to, but basically a review of the literature. And so you can see that in general, there's a slight decline in HMOs over the course of lactation. But if you look at individual HMOs, they do follow different patterns. So this is what I was referring to in what we call secretor status. So a woman's genetic having the 2-fucosyl lactose, 2-fucosyl transferase, that adds the fucose not only to HMOs but also onto cell membranes. And so, for example, in a lot of European countries, you see that it's 22 to 23% of the moms, but just like Bert mentioned with the LCPUFAs, there's a lot of variation. So in South American countries, you can see in Bolivia, Peru, and Brazil and Argentina that most of the women are secretors, and so their milk is very predominant in 2FL, whereas mothers in Africa, on average, had the lowest percentage of secretor status. So currently, we're adding 2FLs to all infant formulas, but not all babies are getting human milk with 2FL. So why do we care? You know, basically, you've probably heard a lot about this, that HMOs are multifunctional for the human infant, and we're really, I think, just scraping the surface in terms of our understanding, and particularly at the mechanistic level. But, you know, they affect numerous glycan-mediated processes, a lot of them within the gut, microbial colonization, specific strains of bifidobacteria, B. infantis, as well as Bacteroides, can utilize these HMOs. There's also in vitro evidence predominantly that it can, HMOs can affect barrier function and gut development. And probably some of the strongest evidence is that many pathogens have evolved to bind to fucoses and sialic acids on cell membranes. So the presence of these fucosylated and sialylated HMOs basically can act as decoys and either bind up the HMOs within the lumen and pull them out. So we can see examples of the rotavirus or norovirus actually being shed into the stool of an infant or an adult, but it doesn't have an opportunity to bind to the cell membranes. We also see that some HMOs, a very small percentage, can enter the circulation and may have systemic effects as well. And one large area of interest recently is the gut-brain axis, where these changes in HMO and the metabolites can be impacting the brain, and also directly potentially providing sialic acid for the brain. So because of this broad range of positive outcomes, there's been a big interest in the potential to start to add these to infant formulas to help to narrow that gap. And so currently, there's 7 synthetic HMOs, predominantly from fermentation, but also produced in other ways. And so these are the 7 up here. I had to add DFLNT to this one. But you can see there's some of the simpler structures, but we have sialylated, fucosylated, and some of the acetylated or neutrals. And again, I'm going to focus primarily on the studies where these have been added to term infant formulas without the presence of other probiotics or some of the hydrolyzed formulas. So the 2 first studies added either a single or 2 HMOs because that was what was available. But as you can see from the out in the booths, that there are some that are now adding more. So I really want to give you an overview because some of these are a little bit older studies, but some of the early ones with Marriage and Gehring, where they had a breastfed reference. This study actually, they included galacto-oligosaccharides, so they were going for a total 2.4 grams per liter of combination prebiotic and HMO. The doses that they looked at were 0.2 or 1 gram per liter, which is quite a bit lower than a typical secretor mom. And they only added 1. The Puccio study, a little bit higher concentration, 0.5 gram of 2FL and 1 gram of LNNT. Just to refer, so these are from the recent paper, so you can see where these are sitting in terms of the typical concentrations and ranges in human milk. So these are some newer studies. Parshat came out just in 2021. Again, a much higher total HMO concentration, and some of these you can see are getting close to the range in human milk. There's also, and I saw part of a presentation this morning that included this. I've only seen this in abstract form as well as in clinicaltrials.gov, but this is actually formulas that are including 5 HMOs. And so, you know, we're definitely starting to narrow that gap a bit more. And just to summarize the overall results, and here I'm comparing to the formula-fed control. And what I would say just overall, that the weight, length, head circumference, so the overall growth, there were no significant differences. In most cases, the GI tolerance, stool consistency, stools per day were similar, except in this study, again, possibly because they were more at 5.7 gram per liter. These were some of the Gehring study actually looked at some cytokines and were able to show, I think, more of a functional outcome, where they found a 29 to 83% reduction in serum pro-inflammatory cytokines, and the levels were actually similar to human milk. And in the Puccio study, they also looked at maternal or parent-reported comorbidities, and they found lower bronchitis and lower use of antipyretics and antibiotics. So definitely, they've been showing safety, and there's some indication of efficacy. So now stepping back, so this is what we see when we add the HMOs to an infant formula. And then this is from a recent very nice review by Norbert Sprenger, where we were looking at, these are the types of studies, so these RCTs I just mentioned, as well as observational studies. So these are associations between HMOs, and in some cases it's diversity, some cases it's specific HMOs, and the reduced risk of health-related outcomes. So I think that this is some of the strongest evidence, particularly for some of these infectious diseases, that the presence of HMOs in milk, as well as in the RCTs, was reducing the risk of some of these health-related outcomes. The other topic that we hear a lot about is growth. And there's been a number of studies, so here predominantly observational studies, that are suggesting that there's some association between either the HMO abundance or specific HMOs and various growth outcomes. But basically what you're seeing is this is positive, this is negative, so there's inconsistent and oftentimes contradictory associations. The effect sizes are modest, and they're all within the range of normal growth trajectories. And importantly, on that slide I showed you, in all of the RCDs, there's never been any reported differences in growth of those infants when you add the HMOs to the infant formula. So at this point, whether HMOs can improve growth in term healthy infants doesn't seem to be well supported. There is a suggestion, though, that HMOs could potentially improve growth in malnourished or preterm infants. This is unknown and should be studied. So I want to talk about another recent study that was just published, where the authors went back to the Puccio study. So this was the study where they either added half a gram of 2FL and a gram per liter of LNNT. So to remind you, the clinical observations were that there was reduced parent-reported bronchitis and lower respiratory tract illnesses. They also, in another paper, showed there was modified fecal microbiome and metabolites. So in the group getting this combination of 2FL and LNNT, they found differences. They found higher bifidobacteria and higher acetate. And so they went and basically used a sparse partial least squares discriminant analysis and machine learning to go back to see, were there any associations or relationships between these clinical outcomes and the biological measures. So basically this is the PLSDA. So this is the variance explained both for the metabolite as well as the cases and controls. And in this case, I'm just going to focus on the lower respiratory tract infections. So you can see that they were able to pull apart the cases and the controls, and they had about a 2:1 ratio. So then when they started looking at what were the components, what were the factors that were loading into pulling these two groups apart, they found some positive and some negative factors. So here they were finding that bifidobacterium abundance, the presence of fucosyl glycans, so basically the 2FL, the product, which would be the test formula, and the percent acetate in the stool were all basically positive. So it was a loading weight, but the directionality was responsible for pulling them apart. So then they went on to further look at, so this is some of the actual data where they looked at cases and controls, and these are the different metabolites, the volatile fatty acids. And what they found is that in the cases, there was a difference, there was lower acetate. statistically. And also in the cases, they saw a reduction in the B. longum subspecies infantis. And that's one of the B. longum that has the HMO cassette that allows it to metabolize. So then they looked at the relationship between the abundance of B. infantis and acetate and found a nice linear relationship. And then when they looked at different species, again, the strongest, they saw positive correlations with the sum of bifidobacteria, longum, subspecies longum, and subspecies infantis, but not with other species of bifidobacteria. So again, this was a nice example of where we can go back to existing data sets and apply some of the newer techniques. So I just want to kind of end with what I think are some of the future opportunities. And again, many of you may be familiar with this, I would say a really nice series of studies over the last decade by Lars Boda's group. And so Lars is at UC San Diego, and he started in a rat model of neck and very elegantly showed that a specific HMO, DSLNT, was improving survival and pathology scores in this animal model. And he cleaved off like one sialic acid, so he showed you needed both sialic acids, you needed the full structure. He then went on to collaborate with a group of neonatologists to basically look at, was there a relationship between DSLNT and in mother's milk and preterm infants with babies who developed neck. And they did find that DSLNT was lower in the milk of mothers of preterm infants who developed neck. And then more recently, in a study that I think got a lot of press, it was with Christopher Stewart and Nicholas Embleton. So they basically applied methods where they could look at the correlations, and they also found some microbial factors, but what they were able to show is there was actually a threshold cutoff which was able to have a sensitivity and a specificity of 0.9. So by measuring the level of DSLNT in milk, they were able to have a very high specificity for an infant who would be at risk of developing neck. So it's really that biomarker that we're looking for. And you know, he's recently published a paper where we can maybe get to a bedside device where you could actually measure these and do point of care at the bedside. Right now, producing DSLNT is challenging, but you know, technology will be able to solve that problem. Currently, preterm infants don't contain any HMOs, which I think is a huge gap. So to summarize, HMOs are multifunctional components, and again, if you look at the brochure that was developed, you'll see lots of different functions in the studies that support those. They really are, I think, going back to the beginning, I mean, this is, the question we always have is, why is there so much in human milk? Why do we have this variability? And you know, this is a component that mothers spend a lot of energy producing that doesn't nourish her infant, but it's definitely providing other benefits. The studies have all shown that the levels and the combinations that have been supplemented are safe and achievable. And again, I think some of our future directions would be additional mechanistic research. There's lots of preclinical, but can we also apply newer statistical and analytical machine learning AI approaches to existing data sets? The area of HMO and neurocognitive outcomes I didn't talk about, but there's a lot of preclinical animal work in rodents as well as in our piglet models that we use, and also some associations, but we need to be doing more interventions, RCTs, with our cognitive outcome as a measure. I think supplementation to preterm infant formulas as well as other specialized formulas. And another area that's really emerging is applications beyond infancy. So you're seeing a lot of papers coming out in adults with irritable bowel, but also even in the elderly as a way to enhance immune function. So thank you very much.
This is time for questions. If you have any questions. Yeah, go ahead, please.
Yes, hello. Oliver Kromer from Hamburg. Thanks first, both presenters. Very interesting. Thanks a lot. Great work, I think, that was presented. I would have a question for Professor Koletzko, and that is in regard to ARA levels in breast milk, considered somewhat as a reference for formula products. I learned that the intakes of omega-6 fatty acids, as linoleic acid in particular, have been increasing tremendously over the past couple of 100 or even 1,000 years. So I was told our ancestors' diet in the early ages of human development had a ratio of omega-6 to omega-3 to roughly 1:1 or maybe 2:1. So today we're at a ratio of somewhere around 15:1 omega-6 to omega-3. So the question for me is, if we're now looking at ARA in breast milk of women being on a Western diet high in omega-6 linoleic acid, one could speculate that relatively high ARA levels might be associated to that income, and that our early ancestors basically may have had considerably different breast milk composition, which one could speculate the infant's needs were more optimized on. So that would be a question. What do you think about that?
Thank you. It's an excellent question. Indeed, yes. Over the last 50 to 100 years in Western countries, the dietary supply of linoleic acid has markedly increased, and the ratio between linoleic to alpha-linoleic acid has increased. And you can see that in studies on human milk. If you look at human milk studies since about World War II to now, you see in different Western countries a marked increase of linoleic acid in human milk, particularly marked in the US, less so in Europe. There was more linoleic acid in the diet in the US, but you see it basically in all Western countries. However, that is not associated with a change in arachidonic acid. In fact, if you go around the world, wherever you go, whether you go to a population with a high or low linoleic acid, where the dietary supply of arachidonic acid is high with a lot of meat eaten, or is basically absent in vegan populations, the arachidonic acid is as stable as concrete. It's basically always near 0.5%, as if there was a real strong biological regulation of arachidonic acid. Now, that is not the case for DHA. DHA responds very quickly to maternal dietary intake, and if you want to achieve what the European Food Safety Authority sets as the goal, to achieve at least 0.3% DHA in human milk, mothers need to consume on average at least 200 milligram DHA per day, which translates into basically 2 meals of oily fish, 2 portions of oily fish per week, or if you don't eat fish, then you need to take a supplement.
Yeah, thanks a lot for that answer. I think when you say that ARA is like concrete at a level of 0.5%, I would argue that in looking at all these different studies in these different populations, there is quite a marked range between like 0.25 to 1% ARA. And I think looking at which populations are getting which ARA levels, although it's not easy to draw any immediate conclusions, but there are a lot of Western populations where we know these LA intakes are very high, excessive, one could say, that there is a tendency for also somewhat higher levels of ARA. So I fully support and can fully get that ARA is absolutely important in infant formula. The question I ask myself is, what is the right level? And is the evidence really so strong that you need to have at least the same amount of ARA compared to DHA? Or if I would look at...
Short question, sorry, in order to have the chance to other people.
So the question is good, but data are data. And the data clearly show that the dietary intake of linoleic acid is not predicting arachidonic acid. Yes, there is a certain variation of arachidonic acid, but it's not predicted by linoleic acid. We also did stable isotope studies in women with high linoleic acid intake in Germany and with lower intake in other populations. And the genetics clearly show linoleic acid is not the precursor for arachidonic acid, the immediate dietary intake for arachidonic acid in human milk.
Is it time? Okay, very quickly. It's actually related, and I think you might have answered it. So my thing was, again, evolutionary. There are countries like India which are 90% vegetarian, mothers. And then when you have the wrong genotype, it just concerned me that, where are they getting their arachidonic acid from then? I mean, because if it's so tight, maybe now is not enough time to answer it. I don't know.
Thank you. The concern for the vegetarian and vegan populations in India and elsewhere, in my view, is not so much the arachidonic acid. The arachidonic acid is synthesized to a greater extent in maternal organisms than DHA, and there is a lot of body stores in the liver and adipose tissue, and we have seen in lactation, when you reduce body fat and convert endogenous body fat into human milk, then there is a good source of arachidonic acid. The concern really is DHA in vegetarian populations because DHA levels can be very low.
And is there if there is a deficiency, does that show up in susceptibility in the child's development? Do we know that in the literature?
Well, there is controversial data, as I said, but if you look, for example, at the conclusions of the European Food Safety Authority, they clearly say if you don't provide at least 0.3% of DHA in infancy, then on average, visual development is adversely affected. So that's a strong argument, and that's why the European legislation had made DHA mandatory in infant feeds.
Can I just add congratulations to the second speaker? I mean, we don't talk enough. I work with pathogens, and they're very silated and glycosylated. And we just seem to forget that, when we talk about in the microbiome landscape. So I think for these HMOs to work in the social care, the elderly, is actually a big bonus plus point. So thank you.
There are a couple of questions in online. One is from Ruben Pfefferbaum. Any results in NEC prevention in human preterm using HMOs composition? And the other one, is there any studies in formula supplemented with HMOs in bone or neurological systems?
So for the first regarding HMO and NEC, this is, I think, Lars had done a calculation of how he would need to power to be able to ask that question, and it was pretty much impossible because of NEC being the type of disease that's very sporadic and not high. So that's why right now we predominantly have these association correlation studies. But the nice thing, interesting about the DSLNT is it was a very specific, and it wasn't related to any other HMO or even total HMO. In the future we may see those, but I'm not aware of any. And the other one was related to HMO supplementation with respect to neurological and bone systems. And again, there's a lot of preclinical work, as I mentioned, very mechanistic work in rodents and with my collaborations in the piglet model that are showing some benefits. But again, I haven't seen in the literature results of cognitive outcomes from any of the RCT interventions. There's been a couple correlations, observational, linking different levels, either 6SL or 2FL, to different neurological outcomes. So in one study, like 2FL was associated with motor at a certain age, and the other HMO with verbal at an older age. So I think what we need longitudinal studies where we're following, because is it just picking this up because that's when the Bailey test is more accurate to measure these at different outcomes? But I think those infants are exposed to these HMOs throughout. And so, right now we can't really just say at this point it's this HMO. So I think there's a lot more work. And there's been some studies with looking at body composition, particularly fat and muscle, with HMOs, again, mainly observational, and I haven't really seen bone.
We have time for the last question, please. Go ahead.
Yannick Jüngknecht from Germany. Thank you very much for all the great presentations. I have a question to Professor Donovan. You made an excellent presentation, comprehensive overview about HMOs and potential future perspectives. Just recently, Jan Chakren published a very nice work that HMOs are actually already present in amniotic fluid at 14 weeks of gestational age. So what do you think about any contact of HMOs with the organism before birth? Could there also be any applications, medical areas for the future?
Yeah, that's some more recent publication, but they've been reported in amniotic fluid for several years. But the levels are very, very low, And to my knowledge, there hasn't been shown any functional outcome to that because of the comparator group, it isn't really there because we don't have amniotic fluid without HMOs. But it does bring up, we've really talked about HMOs being made in the mammary gland and secreted into milk, but we can find them in the blood of the mom and in amniotic fluid. So I put that into, we need to do more research in that area. And we need to show that there's variation that could be then related. But, it does bring up a point again of the preterm infant, who I think would probably, in some ways, I see pairs behind you, may not always agree, but I think the potential benefit, just like for LCPUFAs of HMOs, might be more for the preterm infant due to their developmental immaturity.
Thank you.
I think there is a last question there. Last.
Thank you very much, Per Sangil from Copenhagen. Very intriguing, fantastic overviews from both of you. Final, almost philosophical question. Species specificity here. We know there is so dramatic differences between species in oligosaccharides in their milks, and even the LCPUFA issues. Why did the human species develop quite differently, if we should believe that this is really critical for, any comments on the species specificity regarding these two topics?
Well, there was some wonderful work done by Michael Crawford decades ago, who was doing comparatively biological studies on LCPUFA in brain from the rhinoceros to primates, humans, and it's beautiful work. I just want to refer to the hypotheses on the genetic drift, because that's really fascinating. African populations basically all have a high conversion genotype. They can synthesize arachidonic acid and DHA. When we left the paradise and started to do agriculture, maybe 10, 20, 12,000 years ago, went to cold parts of the world like Denmark, we changed our genotype, and now, as I said, about a quarter of our European population doesn't convert anymore. And if you go along the road of human migration to Asia and across the Bering Strait into the Americas, then 70–80% of the population has lost the ability. And the hypothesis behind that is it's the pressure from the dietary exposure. When we started to grow grain, we suddenly had a high intake of linoleic acid. Then that might have been protective, whereas the populations who moved across to Asia, across the Bering Strait, had a higher protein intake and therefore a higher preformed intake of LCPUFA and didn't have the need to synthesize so much. So it's an intriguing thought, what drives the human genotype selection. It's the same for the oligosaccharides, where, as Sharon has shown, in Europe, in China, we have 20–30% non-secretors. In Latin America, there's almost no non-secretors. So why is that?
So, there's the secretor, but there's also Lewis antigens as well, which is, so there's actually 4 potential genotypes for HMOs. I've heard speculation in terms of the selection, as Bert sort of mentioned, was that maybe these HMOs evolved because of the pathogens that were present in the environment, so it was conferring a survival advantage. Janet Williams just published a really nice paper looking at some of the genetics of HMOs and looking at some of the SNPs, and we don't have time, but it's a little bit more complex, and Lars has also published in that area as well. So why I think is a great question. Now, I think some people have talked about brain development as well. My personal feeling is that human milk evolved for immunological protection, and it's a pretty wimpy source of protein, energy, but what was the most critical thing for survival was to get that infant to not, develop a microbiome and not die of infectious diseases, and I think that's why human milk is so chock full of antimicrobial, antiviral components in lipids, proteins, and fats. And it's almost, we're slow growers, and we were meant to be lactating for 2 or 3 years. So I think the investment was in protection and potentially neurocognitive developments, and both of these components, again, have been much stronger for LCPUFAs than HMOs currently in human studies. So I've talked around. I don't think I've answered your question, but these are some of the thoughts.
Thoughts, no?
They were perfect to finish the talk. You have open questions, so thank you very much for your nice presentation. Thank you all of you for attending, and have a good night.